All right, let's set the scene. A 45-year-old guy rolls into your office, huffing and puffing after just climbing a flight of stairs. He's been feeling wiped out lately, and honestly, spends more time binge watching shows at home than he'd like, not by choice, but because of how drained he feels. Backstory: he's got end stage kidney disease, thanks glomerulonephritis, and started hemodialysis 6 months ago through his arm's new best friend, an arteriovenous fistula. So far, he's been pretty on point with his dialysis, sticking to his dry weight and keeping his hemoglobin in check with some iron and EPO on the side. Vitals check: BP's 160/60th classic wide pulse pressure, heart's trucking along at 100 BPM. Lungs: breathing fine, 96% O2 sat. His fistula's bulging like Popeye's forearm, pulsing hard. Carotid pulse: sharp. You scope out the heart, PMI's chilling way over to the left, and there's this soft systolic murmur hanging around, but it's not doing much when he tries the old Valsalva move. Lungs: a few rails at the bases. Hands and feet: warm, but there's just a little ankle swelling sneaking in. So what's tripping him up? A: is his heart slacking and putting out less blood? B: did his mitral valve just throw in the towel and flop around? C: are we dealing with some thick-hearted hypertrophic vibes? D: is the problem brewing in his lungs with pulmonary hypertension? E: or is his heart drowning in all the extra blood from that fistula too much preload? Let's break down this case step by step, pulling in some pathology and physiology to make sense of what's happening. Key clinical clues: exertional dyspnea and fatigue suggest possible heart failure, volume overload, poor oxygen delivery. End-stage renal disease, ESRD, on hemodialysis. ESRD patients often have cardiovascular complications. BP 160/60th mmHg, pulse 100 per minute. This widened pulse pressure, big difference between systolic and diastolic, hints at high output heart failure. Distended AV fistula with strong pulse. The arteriovenous AV fistula is functioning well, but a high flow state can shunt blood away from systemic circulation. PMI displaced to the left, suggests left ventricular enlargement. Soft systolic murmur at the apex. This is likely due to increased flow across the mitral valve rather than structural valve disease. Warm extremities, trace edema, rails at lung bases, signs of fluid retention and pulmonary congestion, classic in heart failure. This constellation of findings, wide pulse pressure, displaced PMI, and warm extremities, points to high output heart failure driven by increased cardiac preload. In patients with an AV fistula, blood is shunted directly from arteries to veins, bypassing capillary beds. This increases venous return, preload, more blood returns to the heart. Lowers systemic vascular resistance, SVR, arteriovenous connections reduce afterload. Increases cardiac output. The heart works harder to keep up with the elevated blood flow. Over time, this can lead to ventricular dilation and symptoms of heart failure. The displaced PMI and rails confirm that the left ventricle is struggling with the excess volume. Why not the other choices? A: decreased cardiac output. This would present with cool extremities, low BP, and narrow pulse pressure. This patient has the opposite widened pulse pressure, warm extremities, and hyperdynamic circulation. B: flail mitral leaflet, mitral valve pathology like rupture or prolapse typically causes severe mitral regurgitation, leading to hollow systolic murmurs and signs of acute pulmonary edema. This patient's murmur is soft and does not indicate structural valve damage. C: hypertrophic cardiomyopathy, HCM, would present with left ventricular outflow obstruction, a harsh systolic murmur that gets louder with Valsalva, and often a family history. The absence of dynamic murmur makes this unlikely. D: idiopathic pulmonary arterial hypertension, PAH, typically presents with progressive dyspnea, loud P2, and signs of right heart failure, e.g., jugular venous distension, hepatomegaly. This patient's symptoms are more aligned with left-sided failure due to volume overload. Final answer: E: increased cardiac preload. The AV fistula increases venous return, creating a high output state that eventually leads to heart failure. This is a classic mechanism of high output heart failure in patients with ESRD on dialysis.